Good morning, everybody, and welcome to this webinar on Nevada Senate Bill 330 related to breast cancer screening and diagnostics, presented by the Nevada Cancer Coalition and Susan G. Komen. My name is Connor Sweeney. I'll be the moderator for the duration of this presentation. My official role is that of State Policy and Advocacy Manager with Susan G. Komen. So I'm a professional advocate and a lobbyist on behalf of the breast cancer community in Nevada, California, and Utah. So then I think we have an agenda slide up next. So our agenda this morning is, or I guess this afternoon now, is going to include a brief overview of 2023 legislative session in Nevada, a summary of SB330, and background on breast cancer screenings and diagnostics, including the implications for this new law has for both patients and providers. And then finally, as Carrie mentioned, we're going to have some time at the end of the presentation to address questions from the audience. And I think tentatively, we may have our bill author, Senator Roberta Lang, popping onto the call to say a few words if she is able to make it out of her previous meeting on time. So today you're going to be hearing from Carrie Harrington and Dr. Siobhan Harrigal. Carrie is the executive director of the Nevada Cancer Coalition. She is an experienced advocate. Each legislative session, she works with the coalition's policy committee and partners and state legislators and community advocates to pass legislation to help reduce the burden of cancer in Nevada. She's successfully run bills to ban indoor tanning for minors, expand sun safety in schools, increase access to cancer medication, and of course, this bill to expand insurance coverage for screening and diagnostics. And so in this past year, she worked with partners, including myself at Susan G. Komen, to pass this bill. Dr. Harrigal is a radiologist and specialist in cancer imaging. She graduated from Stanford University's radiology residency program in 2011 and also completed a fellowship in breast imaging from Stanford in 2012. After more than a decade working at Northern Nevada hospitals, she's now the face of personalized imaging consultants who work with cancer care specialists in Reno. Dr. Harrigal has presented numerous times for the Nevada Cancer Coalition on the importance of early detection and educated lawmakers by testifying to the legislature in support of bills like SB 330. Okay, so before I turn it over to the main speakers, I just want to give a brief overview of the legislative session that occurred this year. The Nevada Senate and State Assembly meet every other year to consider legislation and budget proposals for the state. The legislative session really is just 120 days, so it's typically a very fast-paced environment. This year, they introduced and considered over 1,000 bills and resolutions, so that's a lot of work to cram into such a short period of time. And that can make it difficult to pass meaningful legislation. But of those 1,095 bills that were introduced this year, just around 569 of them became law. This was the governor's first legislative session, and we saw him veto 75 bills that were sent to him by the legislature. So we're very happy and honored that he signed Senate Bill 330, which passed the legislature with bipartisan support. And with that, I'll pass it over to Carrie Harrington.
All right. Well, good afternoon, everyone. Thanks for joining us. We're still trying to ensure all our presenters are online here, so my apologies. All right. I think we've got everyone going, and as Connor mentioned, we may have Senator Lang join us as well, and we're excited about that. So a quick background on Senate Bill 330 and how it came about. Essentially in 2019, a number of our cancer centers were seeing more late-stage breast cancer cases than they'd ever seen before. I think we have everyone on now, so that's good news. Or not quite. So we will keep working on that one. So we wanted to come up with solutions for this issue. We formed a statewide breast cancer work group to collaborate on this issue, and ultimately, of course, our goal was to save lives. Dr. Harrigal and I were reminiscing earlier this week about a meeting that we were both at, where she grabbed me after the meeting and said point blank, "Carrie, we've got to fix this. And I want a bill." And well, we ended up getting a bill. So we're very excited about that. Dr. Harrigal's been the driving force in these efforts every step of the way. And I know she's still trying to get on the meeting, so I apologize. Hoping Kristen can get her set up here. So as a state, we identified numerous barriers and began collaborating, and you're going to hear this word again and again. We collaborated on the following strategies in Nevada. First, to address confusion for patients and providers due to varying screening recommendations. As you know, there are 6 different national entities that have varying screening recommendations, so it's confusing. So our physicians chose to promote the most up-to-date and data-driven recommendations across our state, and those are from the American Society of Breast Surgeons. Together, we made advances in patient education and raising awareness about early detection to save lives. And while we're all here today, we began working to remove cost barriers and increase access to breast cancer imaging by changing the law in our state. And next slide, please. Great. And I'm just going to ask Kristen if we've had any luck getting Dr. Harrigal on board.
No,
so breast cancer, no. Okay. Breast cancer remains the costliest cancer in the United States. It's got the highest treatment costs, the highest patient out-of-pocket costs, and yet the costs just to find breast cancer and screen for breast cancer are already extremely prohibitive. We know thanks to the ACA, we've got widespread access to preventive screening mammography available to millions of people at no cost. However, if your patient is at high risk, or if the results of a mammogram are in question, then they need additional testing. Unfortunately, these additional tests may leave a patient with hundreds to thousands of dollars in out-of-pocket costs. And as you can see, this is the #1 reason that people delay and or never get these recommended tests. Next slide, please. So again, just speaking to the costs and for diagnostic imaging as well. So I'm going to go ahead and move to the next slide as well. Thank you. So I'm not sure if Senator Lang's been able to join the call. The purpose of our work to change the law was really to eliminate these out-of-pocket costs for medically necessary tests. We know that Medicare and Medicaid already provide these tests at no cost to patients. Therefore, the law that we were seeking really provides parity to our commercially insured patients. While we sought a bill sponsor during the 2021 legislative session during COVID, we weren't successful, unfortunately, but we were truly grateful the following year to collaborate with Senator Lang, and she took on this bill. Senator Roberta Lang took on SB330 and helped us build this bill and the language to incorporate into our law. And with much collaboration from our partners, and many of you probably on the call today, as well as breast cancer survivors, the bill was passed unanimously by all Nevada legislators. And subsequently, as Connor mentioned, it was signed by our governor, thankfully not one of his vetoes. And can we get the next slide, please? Thank you. So the components of this law go into effect January 1. So as of January 1, the following are available to your commercially insured patients with absolutely no out-of-pocket cost to them. Annual mammograms to all insured patients 40 and above. It's really important to note that this law provides for annual mammograms, which aligns with the recommendations from American Society of Breast Surgeons. Further, it was really important to Senator Lang that these services are available to all individuals. So you'll notice if you do venture into the law, into our Nevada revised statutes, that the word women was removed. So you'll see insured, you'll see patient. Those are the words that we're using instead of the word woman. Secondly, it covers imaging tests to screen for breast cancer when medically necessary for people who are determined to be at high risk but asymptomatic. So you'll hear more about that from Dr. Harrigal. And third of all, it covers diagnostic imaging tests when medically necessary to rule out breast cancer or confirm the need for a biopsy. So these are all imaging tests that would be covered, again, with no out-of-pocket cost to your patients. Next slide, please. As with many of our laws, there are some exemptions. So those who are covered by federally regulated insurance plans, these are plans that are not held to state law. So ERISA plans are self-insured companies you might have heard of, such as Culinary Union in our state. Those follow federal laws and unfortunately are not included in what we pass through SB330. Public Employees Benefits Program, also called PEB in the state, for our state of Nevada employees, and then local government public employee plans. Those were exempted, unfortunately, this time around. And then for the final slide for me, thank you. As you can see, Nevada was one of almost 20 states at the time who had enacted this legislation. More states have similar laws in play, and we're hoping that the entire map will be pink sooner rather than later. So I'm hoping we have Dr. Harrigal on the call.
Hi there, I'm here. Thank you, Carrie and Connor.
Fantastic. I'm passing you the microphone, and here is the fabulous Dr. Harrigal. We're so glad to have you, and thank you.
You're too kind to me. Thank you so much. I'm so excited to be here. So we wanted to talk more about why this is important. So breast cancer affects many, many people. We all know people who've been diagnosed with breast cancer. It affects our neighbors, our family members, and our friends. 3/4 of women who are diagnosed with breast cancer have no family history, and they're not considered high risk. The most significant risk factor is being a woman and getting older. Every 12 minutes, a woman in America dies from breast cancer. Breast cancer does not affect all women equally. Black women have a significantly higher mortality from breast cancer than other ethnic groups. The disparity is about 40% higher deaths compared with white women. Breast cancer is the leading cause of cancer deaths for all Hispanic women in America. And breast cancer really has a huge financial impact on women. Many, and some men, as we know, men also get breast cancer. Patients who are diagnosed with breast cancer face a huge financial burden. They often have to pay hundreds or thousands of dollars even before they're diagnosed with breast cancer. So this bill is really important in that it takes away those out-of-pocket expenses so that this financial burden is eased. Next slide, please. So as far as risk factors for breast cancer goes, the American Society of Breast Surgeons is the recommendations that we go off of. All women aged 25 and older should have a risk assessment to determine their personalized risk of breast cancer. And risk factor calculations can be done using a few different models. One of them is the Gale, one of them is Tyrer-Cruzik, the TC calculator. Average risk women should start screening for breast cancer at age 40. And screening should really continue until a patient's life expectancy is less than 10 years. So many patients live to their late 80s and 90s. There's no reason to stop screening these people for breast cancer. Keep screening until other health conditions pose more of an existential threat than breast cancer would. People at higher than average risk of breast cancer should start earlier than age 40 and should be offered additional tests that we'll talk about shortly. Next slide, please. So, high-risk patients. This bill really impacts people who are at high risk. Who is high risk? High-risk patients are patients with greater than 20% lifetime risk of breast cancer, based on risk calculations like the Tyrer-Cruikshank or Gale or other modified risk calculators. High-risk patients, so people with greater than 20% lifetime risk of breast cancer, should get an annual mammogram once a year, every year, 10 years before their closest family member was diagnosed with breast cancer. So, for example, if my sister was diagnosed with breast cancer at age 45, then I would start 10 years before that at age 35, not before age 30. And high-risk patients should get an annual breast MRI once a year, every year. And again, 10 years before their closest family member was diagnosed. And breast MRIs are very expensive, and so that's why it's very important that we have a bill that covers this additional cost so that we do not have an extra financial burden for these high-risk patients. Next slide, please. So we're going to talk about the different kinds of imaging. So in general, there's two different kinds of imaging. So supplemental imaging is extra pictures for someone who is high risk. This is someone who's previously had breast cancer or has a genetic mutation and is high risk. Supplemental screening is in addition to mammograms. It does not replace mammograms. So that could be screening breast ultrasound for women who have dense tissue. It could be breast MRI for someone who is at high risk, which is greater than 20% lifetime risk of breast cancer. That's different than diagnostic imaging. Diagnostic imaging is like problem solving. And that's done when a patient has a lump that they can feel, or pain, or another issue that is used to problem solve. And so diagnostic imaging is also covered, thankfully, by this wonderful bill. Next slide, please. So the three major types of breast imaging, and we've talked about this a little bit, are mammogram. Mammogram is a low-dose X-ray picture of the breast. Typically, two views are done, a top-down view, a side view. The mammogram that's standard is just normal pictures that are done in two different directions. Tomosynthesis is a 3D mammogram where the tube moves and it takes like a high-definition movie, also using low-dose X-ray pictures. So mammogram and tomosynthesis are kind of interchangeable. Most mammograms include tomosynthesis. It is just a better mammogram. It helps find more breast cancers, especially in women with dense tissue. It also decreases false positives, so callbacks for extra pictures. So this covers mammograms, 3D mammograms. It covers ultrasound. Ultrasound is done in two main different ways. Number one, screening breast ultrasound, where we look through dense tissue to try to find extra breast cancers. Screening breast ultrasound has been shown to find extra breast cancers, especially in women with dense breast tissue. Also, ultrasound is used as part of diagnostic imaging to help problem solve when a patient has a lump or an area of focal pain. And then MRI is where you go into a tube, kind of like Superman, where your arms are up and pictures are taken. You get an injection of contrast into your arm. That has by far and away the highest sensitivity of finding breast cancer out of all the tests. But it is only really used for those high-risk patients and for people who are diagnosed with breast cancer in certain circumstances. All these tests are covered. Next slide, please. So we talk about people who are high risk, greater than 20% lifetime risk of breast cancer. But there are other factors that cause us to be at higher risk, even if we don't reach 20%. Those are getting older. Having dense breast tissue is a risk factor for breast cancer. Having dense tissue not only makes you more likely to get breast cancer, but it is also it's also harder to find your breast cancer on a mammogram. So it's kind of a double whammy. And so we like to offer people with dense breast tissue other tests such as the 3D mammogram and ultrasound in order to find those extra tricky breast cancers. Genetic mutations, the BRCA, BRCA, BRCA 1 and 2 genetic mutations also give patients a higher risk of breast cancer. People who've previously had lymphoma and have been treated with mantle radiation to their chest are at a high risk of breast cancer. People who have a family history of breast and ovarian cancer are at a higher risk, and people who've previously had breast cancer. Next slide. This is a picture of us when we were getting this bill passed, and this was an amazing journey, and it was a true collaboration, and it took hard work and years of persistence and hard work, and we're so excited to have made this huge impact for the people in our community throughout Nevada, and to reduce financial burdens, and to really promote health equity, and to improve the lives and save lives for people all over Nevada from breast cancer. We have time for some questions and answer. Here's all of our contact information in case you'd like to contact us privately. And Carrie and I will open the floor and hopefully be able to answer all of your questions.
Looks like we do have a couple of questions. We have one from Kristen. Are biopsies covered both stereo and US guided? So this bill is strictly limited to diagnostic and supplemental imaging and eliminating cost sharing for those particular services. Biopsies were not a part of this bill. So I'm sure the biopsies are covered by most insurers, but they're just not covered at no cost. Like the subject matter here. We also have a question. If someone has had lumpectomies that were benign in the past, is a diagnostic test acceptable to ask for?
Yes,
yes,
absolutely. Absolutely, yes.
Are uninsured patients covered? So unfortunately, the bill applies to commercially insured patients pretty strictly in that sense. So unfortunately for uninsured patients, SB330 is not applied. Or Carrie, jump in.
Correct. This particular bill was specific to commercial insurance. However, as mentioned, Medicaid covers these services. And then we do have a program in Nevada called Women's Health Connection. For those that are uninsured, they can often get covered through that program as well, which would provide similar coverage.
For imaging entities who charge the patient for the 3D portion, will those charges be eliminated for patient? I mean, I believe so. If I'm understanding the question correctly, then yes.
Yes, they should be, and that was another piece of how we wrote and built the bill. As new imaging technology comes forward, we didn't want to specify, only mammogram, only MRI. So we wrote the bill very generally to cover imaging tests. So that should include 3D.
That's a wonderful question, Melissa. Thank you. Are we working with the Division of Insurance on making sure commercial insurers comply with this? Will there be penalties on companies and policies that do not include this? So I actually have reached out to some folks at the Department of Insurance. I haven't heard back from them yet, but that reminds me I need to do some follow-up. There are not any specific penalties included in this bill, so we didn't add any specific penalties to statute. So just whatever powers that the Department of Insurance already has are what they're able to enforce this bill with. What about 6-month follow-up exams? Carrie, Dr. Harrigal, yes? All right.
Yes, that's part under the umbrella of diagnostic imaging. 6-month follow-up IRADS 3 is included in that as well.
Another question. Historically, it has been difficult to get breast MRI authorization for high-risk patients. Have insurers given any guidelines they will be using for approval? Not that I'm aware of. That has been a concern of ours when we've worked on this legislation in other states, that now that these services are, required to be covered at no cost, will they just be, subjected to a ton of prior authorization ahead of time? But to my knowledge, the insurers themselves haven't issued any guidelines. I don't know if Carrie or Dr. Harrigal want to chime in, but we haven't heard much on that end. Okay. Historically, it has been difficult. Oh, wait. We already went through that one, I think. What is the likelihood for trans women and trans men to develop breast cancer, and are these barriers for them to access? Are there barriers for them to access these services? Carrie, Dr. Harrigal, do either of you want to take this one?
I don't know the likelihood. Dr. Harrigal might have that answer, but again, we specifically pulled the word woman out of the current law, so it applies to anyone and everyone.
I agree with Carrie. Men do get breast cancer. Trans people absolutely get breast cancer. There are barriers that they face in addition and this bill has really helped by having more inclusive language so that they are not turned away and cannot be denied coverage. Any patient who has a lump, an area of concern, has to be covered. And so I apologize, I do not know the statistics. People who do take estrogen do have a higher chance of developing breast cancer. And because of the modified language, we hope that that will promote health equity for all of our patients.
Okay. And oh, well, thank you for sharing some additional information. I just want to highlight this in the chat. Someone said, for those who are uninsured, you can also refer them to the Red Rose program, which covers breast health services. Thank you very much for sharing that info. And yes, those prior authorizations do cause huge delays in patient care. That's something we're working on in many other states as well.
And I believe we were hoping, again, the wording of the law and stating that it was medically necessary. So if a physician has ordered it, we're hoping that does prevent some of those delays and prior authorizations. So giving more power to our providers.
Absolutely. And I do have one thing to add, since earlier Carrie mentioned the exemptions included in this bill, which include ERISA plans and the federally regulated high deductible plans, that Susan G. Komen is in fact working on federal legislation to bring in those federally regulated plans, high deductible health plans, and ERISA plans. It's been a bit of a process since Congress has been so gridlocked, and how do I put this politely? Things have been a little crazy in Congress right now, so that has sort of given us some roadblocks, but that is being worked on. So everyone, I think those are the end of the questions. Thank you, Melissa, and thank you, everyone.